So one of the things I've found most interesting in the last couple years has been the influence and the importance of social media and actually supporting large sarcoma centers and helping patients get to sarcoma centers by educating new patients. Because the patients are actually educating the patients that are coming in, based on the statements that came out of Lydia Shriver and the Sarcoma Foundation of America, where they were pushing this idea that sarcoma patients will probably be treated more optimally with people who do this all the time. And so I think what this has led to is a number of large centers. There's about 40 medical oncologists in the country, because you have to be at a large academic center to support somebody that only treats sarcoma, to have the patient volume to do it. And so what I think is really interesting, and maybe we can just go across the panel, is we can really talk about the patient volume in terms of how many patients you treat, how many patients you see in second opinion, and really talk about your multidisciplinary care at each institution so we can learn a little bit about what's going on everywhere from MD Anderson to Miami. So if you would like to start, Dr. Patel.
Sure. So our center sees more than 1,000 new visits in a given calendar year. I think they're distributed within medical oncology and surgical and orthopedic oncology. Radiation oncology can occasionally see some new patients. This may account for about, I want to say, maybe 90+% of all the sarcomas that come to MD Anderson. There are site-specific nuances, if you will, where a head and neck sarcoma might go to head and neck surgery first, or a gynecologic sarcoma may go to the GYN team. But that's how the numbers pan out. And I think, again, despite the numbers, we do have a program where we talk amongst each other. So there are multidisciplinary conferences where these cases are discussed and treatment plans are outlined.
And then at Harvard?
So at Harvard, we have a combined center between Dana-Farber Cancer Institute and Massachusetts General Hospital. And collectively, we see about a similar number, about 1,000 new patients a year. We don't treat all of them. I mean, a lot of them are opinions that come from other places in New England or other places in the country, or just like other centers here, other places in the world. I think what's really important is that we stay in touch with those patients and their physicians to help guide them in treatment, because it's just impractical for patients who live 8 hours away to come see us for every treatment. So a lot of our care is spent in helping to guide care that's provided other centers, but being available for patients also when they want to come back for restaging, or especially for new clinical trials, or for the inflection points in their treatment when they're having progression or toxicity that needs to be managed. So it's a moving target in terms of the number of patients we're actually treating at any given time, but it's a combination of patients that we are directly administering drugs to and other patients that we're providing ongoing consultative services to.
I think one of the neat things on this panel is that Robert Jones is here, and he can kind of give us more of a European perspective, because things are managed slightly differently there. And so what is the volume at the Royal Marsden?
Thanks, Brian. So the volume at the Royal Marsden is similar, so over 1,000 new patients each year. Again, with the nuances described by Dr. Patel and Dr. Wagner, many patients come for second opinions, come from abroad, and we work with local oncologists both in the UK and elsewhere to guide treatment and to help with the decision-making process at certain points. Also, some patients are referred directly to the head and neck or gynecology service, for instance. The system in the UK is certainly very different to the system in the United States, in that all sarcoma patients need to be referred directly to a sarcoma centre on diagnosis, which in many ways, in view of the geography of the country, is relatively easy to do. It does create issues, as Dr. Randall mentioned, in terms of workload, particularly for our surgical team, with many patients being referred with lipomas, for instance. And so it's difficult sometimes to find that balance in terms of referrals coming in. How do we triage those referrals? But generally, the system works very, very well.
I think it's interesting that, you lead the 3 granddaddy programs, and if you put in Memorial Sloan Kettering, the 4 granddaddy programs. I lead a program at Washington University in St. Louis, which actually has a different demographic, and I think as we go this way, you're going to find that it's interesting we put the 3 of you here and the 3 of us here. Washington University only sees 600 to 700 new patients a year, but we treat most of them. And we're a large trial center, and just given the geography of the United States, you've got the Northeast Corridor where you have a good majority of, the medical oncologists that treat sarcoma, and then you have the middle of the country. And I think Jonathan will tell us about the challenges of Florida, but I think the Huntsman's, has some similar challenges, which is patients travel. This patient population will travel immensely. I have patients that drive up from New Orleans and down from Chicago and from Wichita, Kansas, just all for trials because they're in the middle of the country are less sarcoma resources than, say, on the coasts. But, we have a multidisciplinary team of 30, all with dedicated surgeons. We actually meet together. That's really kind of this encouraging, quickly moving program. And so, we've developed something based on everything you've all taught me that really, I think, has been well put together. And so as we move a little bit farther to the west, you end up at the Huntsman.
Right, this is a nice transition. Our numbers are similar to yours. Interestingly, when I looked at the post at Utah, I rolled out a map and saw that, not being from there and having been on both coasts, the University of Utah and Huntsman Cancer Institute and Primary Children's Hospital, which is all a conglomeration, sees about 14% of the geographic United States, or referral basin, I should say. Now, that's not population, that's geographic numbers. But it does mean that many patients are coming a great distance for their definitive care. We'll see additional patients for a second opinion, et cetera, domestically and internationally. But one of the challenges we face, interestingly, is because these patients are coming from some pretty remote areas of the United States, tumbleweeds floating around down Main Street kind of thing. They're coming to see us, and we need to make sure that we can bundle all of their care, because we know it's going to be definitive, all at that visit. Because again, the resources to get down and see us too is a challenge, and many of these people have families. So another nuance to the issues that we've all discussed.
Yeah, and then I think you have probably the youngest and most rapidly evolving program, having moved from MD Anderson to Miami. I'm interested to hear what's going on at the Celestra at this point.
Yeah, at the Celestra Cancer Center, we also see about 700 new sarcoma patients per year, and they come through a variety of sources. Many are referred directly to myself or Breland Wilkie, or to our surgeons, such as Nipun Merchant and Alan Livingstone. But a critical part of our multidisciplinary team, we actively involve the head and neck surgeons, the dermatologists. We have a molecular pathologist who attends our multidisciplinary conferences. And so we try to pull in even gastroenterology. Anybody who could potentially touch sarcoma at our center, we bring them into the team. And so when they see a new patient, first step is to present it at our multidisciplinary conference. And so that way we have a very streamlined and evidence-based management for our sarcoma patients. And so we see a large number of patients in the Southeast United States. And of course, as any other sarcoma center, patients are willing to travel for their care. We're also the gateway to the Caribbean, South and Latin America. So we have patients who come to our practice from every country in Central and South America, the Caribbean. Many of them move to Miami for their care. And of course, we also have a number of patients in Europe, Middle East, who have homes in Miami and are diagnosed with a sarcoma, move to Miami for their care and stay at their condominium on South Beach. And then when we complete their care, they may travel back to Russia or to Turkey or the Middle East.
Or to Boston. We share patients. We have plenty of patients to go south for the summer, and John and I share patients